Hello, my name's Dr. Amy Russell from the University of Leeds, and this is the first part of a four-part series of training modules that are a result of the Real D project. Real D was a project about making reasonable adjustments to diabetes care for people with a learning disability, and it was funded by the British Medical Association and Leeds Community Healthcare Trust, and it was supported by the Health Facilitation Team at Leeds and York Partnership Foundation Trust. These modules form an overall springboard for you to then go out and start thinking about your practice for patients with a learning disability and seeking support within your own trusts. Please do use them as just a brief beginner's guide, because what we do here is a condensed version of training that took nearly 2 hours, and that was actually training that was a whistle-stop tour of this issue. So certainly condensing them down, I think, makes them more accessible, but it also makes them just touch the surface of what you might need to know. So to share this information with you, I'm going to start sharing my screen so that you can see the slides that are part of this training. So in this session, we're going to cover defining learning disability, coding for learning disability, and making referrals for someone with a learning disability. So, the official definition of a learning disability is a significantly reduced ability to understand new or complex information, to learn new skills, and a reduced ability to cope independently. And it's at onset before adulthood. So an adult who has a brain injury and begins to be unable to understand new or complex information does not have a learning disability and should not be coded as such. I've also included these terms: mild, moderate, profound, and severe. We see them on people's records, and they're actually based upon IQ thresholds when IQ testing was a lot more commonplace, but they're not as meaningful now, and we don't tend to use them as coding. So a lot of people will not have these codes on their records, and they will not have an IQ score. And we are still seeing guidance and legislation sometimes utilising these terms to bracket off groups of people with a learning disability. So your profound and severe population will need this action. But then that falls on the clinician to have defined people in that way, and it becomes quite difficult. I'll explain a bit more as we go on. So every person with a learning disability is different. They can do different things. We talk about functional ability now rather than IQ scores because people have so many different skills in different places. Equally, somebody with a learning disability may have other things that have an effect on their ability to learn new information or retain information. So, for example, you have people with a learning disability who also have autism or dyslexia or mental health problems. Quite a few people with a learning disability have problems reading and understanding numbers. And while some people, the majority actually, have communication issues, some people are excellent communicators and would lead you to believe that through their communication they have actually understood what you're saying and retained that information. But some people are extremely good at knowing when those cues are required in conversation, but not at retaining information potentially. So don't take communication as an indicator of capacity. So this slide I could wear as a billboard. Learning disability is not. It's not just difficulties with reading, writing, and numeracy. Those things could have come about through any kind of childhood that interrupted schooling. And it's not emotional difficulties. And again, that might have disrupted schooling and influenced their achievement. So you cannot diagnose learning disability based on just those things. It's certainly not ADHD or hyperactivity. It's not what we used to call Asperger's and being on the autistic spectrum. As I said, some people with a learning disability may also have autism, but the autism as a standalone diagnosis does not mean learning disability. And the term learning difficulties is an absolute bugbear of mine. The amount of records that I come across in primary care that have learning difficulties coded with no explanation of where it's come from or why it's there. It's often an educational term that has been put on somebody's record in childhood and never really been explained or explored. And it now is a stand-in for all sorts of things and makes people assume that someone is correctly coded for their learning disability. But the code learning difficulties doesn't do anything for somebody. It doesn't place them on a learning disability register. It doesn't flag them as in need of reasonable adjustments. It actually gets in the way of you realizing that this person needs adequate coding because you think it's been done by this term. So please, if you do one thing as a result of this module, search for the people who have a learning difficulty code and figure out what code they should have. So MenCap has a guide on what is a learning disability as well, and we'll talk a little bit more about coding because, as I say, it's a pivotal issue. It sounds quite dull to a lot of people, but actually if somebody's not coded properly, they're not in receipt of the services that they have a legal requirement to, and you're not aware of them. And if they go to another service, those people will not be aware of them either. So you have a legal and professional obligation under the Equality Act to make reasonable adjustments, to make your services as accessible and effective as they would be for somebody without a disability. So really have a think about that and think about the people you see with a learning disability. Is your service right now just as good, and does it have just as good outcomes for those people? And if the answer is no, actually I must admit they struggle more, then you've not made the reasonable adjustments required. Now, I know that you're thinking, what's she on about? You know, some people are just extremely difficult to make those reasonable adjustments for because they need so much. And we are an extremely pressured service. And I get that, I really do. But make what you can, do what you can, and record what you've done and get support if those things aren't working. Reasonable adjustments are not a one-trick tick box exercise. They are try again, get support, change again. It's like an evolution of your service to gradually move towards being as accessible. If you don't make these changes, we end up with direct discrimination and indirect discrimination. Direct discrimination is when you discriminate against somebody because of a characteristic which is defined in the Equality Act as a protected characteristic. So you have said, I've got a patient with learning disabilities and diabetes. They need, as part of their pathway, to be offered education on diabetes. However, I know they just won't understand the education that's on offer in my trust or in my CCG. So I'm not even going to offer it to them. I'm not going to bother. I'll just say they refused. You haven't tried to explain it. You haven't talked to them about that service, and you haven't contacted the education team to find out if they can make reasonable adjustments. So you've discriminated against them on the basis of their characteristic as having a learning disability. Indirect discrimination is slightly more nebulous because, again, you may not realize that your standard procedures do it. If you send a letter for chronic illness reviews that requires the person to call up and book, and if they don't do that, they may actually get struck off the recall, you're relying on a form of literacy from that patient. And I've seen some terrible chronic illness review letters that are, you know, asthma, COPD, diabetes, all of them in one list. And so the person goes, oh, well, I haven't got those other ones, so it can't be aimed at me. Bins the letter because they don't fully understand what's required of them. And then they don't get the recall. So that's indirect discrimination, which can easily happen. You also have a legal and professional obligation under the Accessible Information Act. The Accessible Information Standard. So you are required to ask people if they have communication needs and how they would like you to meet them. Record those needs clearly and highlight and flag them on a person's file or notes, and share that or flag it in a way that it can be shared. And then take steps to ensure they receive information suitable for their needs. So the amount of times I've interviewed clinicians and they say, oh yes, we've got leaflets that we give to people with diabetes about this and that. And I say, all right, are you happy with those leaflets? Yep. Are they any good for people with a learning disability? And they stop and they say, probably not, no. You think, well, have you explored with your patients with a learning disability what their needs are? And not just communication in terms of leaflets, but all forms of communication. How do they want the conversation to happen in the clinic? How do they want you to record the goals that they're aiming for and take those goals home. All of these things need to be discussed as reasonable adjustments. So, going back to basics, identifying people. Identify a learning disability. Ask the person. If you're struggling, there is an inclusion tool on the Get Checked Out Leeds website that you can use, and it takes you through common indicators. Put it everywhere. Put the correct coding everywhere so that people can see that they have a diagnosis, and if they're going into another service, their learning disability and the adjustments they need do not come as a surprise. So we've got a code under the SNOMED CT coding. It's there. I'm going to leave it up for a few seconds so you can jot it down. There's a whole PDF online, this Improving Identification of People with a Learning Disability Guidance for General Practice. It's the first one that comes up if you search that term, and it gives you all the codes you might like to use to have a look through your registers to see who's missing. And this is really important because there's actually very few codes that put people on a learning disability register. So I went out to one CCG, quite a large one, and searched for I think it's 3 codes for Down syndrome. And we found 16 people who had the code for Down syndrome and were not on the learning disability register. So a lot of diagnosis codes do not place a person on the register. And there's an assumption that they should, and they would, but they don't. And so the most neutral one that you can do is this one, on the learning disability register. And then that puts them on the register, flags them, and allows you to then make them eligible for health checks, give them a diabetes care plan, make reasonable adjustments. If they're suddenly admitted into hospital, the flag is there. The learning disability team know that somebody's been admitted who has a flag for learning disability. It's so important. So just to emphasize this, a woman with a learning disability is likely to die on average 18 years before a woman without a learning disability, and from similar causes. So that's 6,570 days lost simply because that woman had a learning disability. And that tells us that she cannot be accessing healthcare in the same way as somebody without a learning disability. That woman cannot be getting the same benefits from her healthcare system because of her learning disability, because she cannot lose 6,500 days if there was not something wrong with our system and our society. There is a serious health inequality here for people with learning disabilities, and it begins with not even recognising their learning disability. And that is one small change you can make to make a huge difference to people's lives. So we use the social model of disability, and we think about the person you're seeing not as a problem person who you struggle with, but someone who the system was not designed for. And we look at changing the system, not the person, and we look at the ways that we feel comfortable and move through our processes, usually because of time pressure and because of mental pressures on us, and we get used to doing things a certain way, but actually for some people those ways do not work, and it is not fair to keep going with those ways. So in terms of health inequalities, people with learning disabilities do have high levels of comorbidities, especially respiratory disease, which I flag here as one of their major causes of death and a real issue right now. We're seeing some terrifying stats coming out of the pandemic of people with a learning disability being 4 to 6 times more likely to die of coronavirus, and that's with the really poor coding for learning disability, which suggests that actually there are a lot more deaths of people with learning disability who weren't properly coded, so it's not been flagged. So we've got a real issue here of a population who are experiencing multiple forms of vulnerability and inequality. We've also got high levels of anxiety and depression, which are really exacerbated by social isolation at the moment. We've got 40% of people with a learning disability with hearing or visual problems. So again, just saying, oh, I got my leaflet that had some pictures in it may not be enough. We may need sign language interpreters who specialise in sign language for people with a learning disability. Now, this may be Makaton for some people whose verbal skills are not very good, but this also may be British Sign Language or an adapted version of that. And the only way you'll know is to ask the person. And if you can't ask the person and communicate with them, ask if you can talk to a supporter and talk to them. And up to 90% of people with a learning disability have some kind of communication problem. So this is a significant issue. You know, you're not going to say, oh, it's a small minority group of a minority group. It's really not. And it's good practice for everybody as well. So what about diabetes? We're here to think about diabetes. Well, because of coding, obviously we've got a problem that any of our stats, any case we try to make about illness, we don't know for sure, but we're pretty sure that people with a learning disability have about twice the rates of diabetes than the average population. We know they've got high levels of obesity and high levels of inactivity. So these were some stats we got when we were doing a study with nearly 200 people with a learning disability and type 2 diabetes. We found a lot of inactivity in people, and it was a real struggle for people to make change in their activity levels. We also have a group of people who tend to be on wide ranges of medication, some of which cause diabetes. And so again, having a look at somebody in their health check and thinking about their medication is a really important part of that review. And so here's Catherine from Change. Catherine is a learning disability advocate, an expert by experience, and she works for the organisation Change. She has diabetes and she also has learning disability and autism. And here she is talking about what diabetes means to her and other people she's talked to who have a learning disability.
It means different things to different people. They know that they'll have to change their diet, and sugar is, well, they can have sugar but not have it every day. And it does mean a lifestyle change, and it will take time to adapt to that diet change, but you will get there. It is hard because you're going to miss foods that you've been used to having, and it is hard to resist them, but you've got to do it for your own health if you want to live longer.
So what I found really interesting about Catherine's story about diagnosing her with diabetes was that at first she didn't take it terribly seriously because she didn't understand what having high blood sugar meant. And she was very switched off by people nagging her about healthy lifestyles and eating. But then one nurse really laid it out for her what might happen if her diabetes progressed. And it was then she started changing her behaviour. So thank you for listening to this part of the training modules. This is part 1. We have 3 others, and it would be wonderful if you could work your way through them. Any feedback or comments to my address at the university, and a big thanks to Leeds Community Healthcare Trust and the BMA, and Get Checked Out Leeds. And thank you to you for listening.